insures almost 3 million Ohioans. It's the largest insurer in the state and in the country, I believe, bigger than Medicare. Is that correct? And Medicaid Expansion has been responsible for approximately 650,000 covered lives that otherwise wouldn't be covered. I feel that I've always been one of the good guys because I practice emergency medicine. We've always cared for anybody regardless of, but this is actually hoped to cover many more people who otherwise wouldn't be. I got to know John Corlett as a colleague at Metro Health Medical Center where I work. Now he is working, actually he chaired Ohio Medicaid under a previous Democratic administration, under Ted Strickland. Now he's the he heads the research organization Center for Community Solutions, and he will talk about that a bit as well. By the way, offerings today will be donated, but I'll mention that later. Without further ado, let me introduce Mr. Corlett. Thank you.
Now, hopefully, I think that works. Good morning, everybody. So I admire all of you coming out on this beautiful Sunday to talk about Medicaid. So you're either all just geeks like me or otherwise just genuinely interested. So what I'm going to do today is sort of cover these three things, because I think a lot of the debates we have around Medicaid today are related to how it started, to its origins. And last year marked the 50th anniversary of the program. Lyndon Johnson signed the bill putting Medicaid and Medicare into place on the same day, actually. So we'll talk a little bit about how the Affordable Care Act changed Medicaid in Ohio and around the country, how it's working, and then kind of what's on the horizon in terms of policy that's sort of being talked about, some good, some bad. And then I want to talk about some of the things I wish we were talking about, some of the things I wish were on the agenda. So I love this picture. You got Harry Truman up there in the left, because Johnson went to Missouri to actually sign the bill because Truman had been sort of pushing for national health insurance from the time he was president. And so when Johnson finally got this bill through, he went there. And this gentleman over here, there's Wilbur Mills in the background. Wilbur Mills was really kind of the power behind getting this done in Congress. But the thing was that it was really, Medicaid was an afterthought in the whole, all the focus was on the Medicare legislation. That's where Congress was focused, that's where the media was focused. They said, I think, that the New York Times in the sort of year-long debate around this bill wrote one article about Medicaid, that it really wasn't something that people were focused on. One of the guys who worked on drafting it said they didn't talk about it for more than a half a day, that's all it sort of took up in terms of the time that they spent on it. And the other thing, one of the reasons it happened was because the Democrats had super majorities in Congress. This was after the Johnson landslide, beat Barry Goldwater. So you kind of think about, could we be headed, I mean, people talk about this Trump thing as if he is the nominee, that it could be similar to 1964. I don't know if that's true or not. But the other thing, the program was at its very beginning kind of linked to welfare. And that was because before Medicaid and Medicare was in place, there was something called the Care Mills Act, Wilbur Mills, and then the Senator Care, also from Arkansas, that provided grants to states to pay for medical costs through sort of welfare organizations. And so that was kind of where this program came out of. And in fact, the legislation itself required the program to be administered by state welfare agencies. So they kind of put it there. And so all those things, I mean, the fact that it was linked to welfare and it's where it started continues to influence the program today. And so I'll talk a little bit about that. And then the other thing I always like to tell people, it took 18 years before every state joined the program. So, there's a lot of focus today on how many states have not expanded Medicaid yet under the Affordable Care Act. That's not unusual, sort of in the history of these things. The last state to join the program was Arizona, and that wasn't until the 80s. So costs immediately exceeded estimates. So that was sort of a precursor of things to come. So the first year costs were estimated at $238 million. They actually went over $1 billion. Now, we would love to have a program. This program cost $1 billion today. The costs were then projected to triple in 3 years. And then Governor Nelson Rockefeller, the former governor of New York, he tried to put through a system in New York where he was actually going to cover half of the state's population on Medicaid, the uninsured. That freaked Congress out. They were like, oh my God, we've got to put some controls in place. And so they set income limits in the program almost immediately in 1967. But you see over time, so you can't see over here, but in 2015, the program, if you counted both state and federal money together, was a little over $500 billion. So it has grown pretty significantly. And the thing to remember too is Medicaid is a joint federal-state program, meaning the state picks up a good share of the costs. So the sort of rule of thumb here in Ohio is for every dollar we spend in Medicaid, about 60 cents is paid for by the federal government, 40 cents by the state. In the case of children, services for children, it's a more generous, the federal government picks up almost all the costs, and the state picks up a very small portion of the cost. So, and because of the program's origins, remember, it was sort of located in the welfare agency in states. Applying for the program wasn't easy. I mean, you had to, first you had to bring in all your paperwork, and that you had to produce all this documentation of check stubs and things like that. Then you had to fill out these applications that were just sort of, 15, 16, 25 pages. Some states required you to get fingerprinted. And then you had to go to that office there where you sort of waited and waited and waited. Then you might be drug tested. That was a thing that some states did. And then you waited for your application to come. So it was it just had that kind of welfare feel, that welfare focus to it, instead of a health insurance program. And just to show you, so this is the landscape in Ohio before expansion. So children 0 to 18 were covered up to 200% of the federal poverty level in Ohio, which for a family of 3 is probably somewhere in like the $40,000 range. So pretty, fairly generous in terms of kids. Actually, when when I was the Medicaid director for Governor Strickland, we actually tried to increase that, but we were blocked then by the Bush administration from doing it, from increasing that coverage level up. So parents were covered up to 90% of the federal poverty level, but above 90%, there was no coverage for you. Childless adults, they were really the group that had no access to coverage. It didn't matter how poor you were. You could have no money at all, but you would not be eligible for Medicaid. And then disabled under the age of 65, you went up to just about, I think it was about 65%. But other than that, there's some other special programs for people with disabilities that allowed them to get covered, but they were sort of difficult to manage. So the Affordable Care Act kind of changed the framework. We went from a welfare program to a health insurer, because under the welfare program, it was kind of only linked to this notion of the deserving poor, children and their parents, the elderly, blind, or disabled. It was linked to cash assistance, and it was hard to get on and hard to stay on. One of the sort of well-known facts about Medicaid was one of the ways that states used to control the program, the cost, is they would just add extra hoops you had to go through to get on it. And that was like I remember when I was Medicaid director, we used to require, if you were age blind disabled, to get your Medicaid redetermined every 6 months. Well, it wasn't like in 6 months you weren't going to be aged, blind, or disabled. I mean, sort of once you're in that category, you're in it. And so we eliminated that, and the feds allowed us to go to 12-month eligibility. So that's how and then the other thing that happened, remember, welfare reform, there's a lot of conversation about that these days. But that also sort of delinked welfare and cash assistance, because at the time it was thought that Medicaid was the thing that brought people onto welfare, that they wanted health insurance, and so that was why they wanted to get onto cash assistance. But really, the biggest change then comes in with the Affordable Care Act. And you can see now it covers over 65 million, or 1 in 4 Americans, and that's similar to Ohio. Every 1 in 4 adults, a little over 1 in 4 adults in Ohio is covered by Medicaid. I would imagine if you looked at kids, it's probably half the kids in the state are covered by Medicaid, because kids on average tend to be a poorer population. Largest single insurer, streamlined the eligibility and enrollment process, and it's now sort of driving payment and delivery reform. So here's applying for Medicaid today. No face-to-face interviews. You're not allowed to require that. No drug testing, no fingerprinting. That's not allowed. There's a streamlined application. So if you go to the exchange or wherever, the application is the same for everybody. So it's just one application across all 50 states, and that has to be reviewed and approved by the federal government. No wrong door. You had to go to the welfare office to apply for Medicaid, or you went to the, if you got private insurance, you got it someplace else. Everything can go through these exchanges. You can also apply online. It's much more simple than it was in the past. The other thing is this, and this, I will say though, not all these things have gone smoothly, but and it's, I think, been difficult. But the other thing is it's this database proof of eligibility, meaning that, and this is one of the things that always used to drive us crazy in Medicaid, was we had people apply for these different programs. We had all the documents, we had all the information in our systems, but we couldn't access them. We couldn't see them to make so that people didn't have to go through this more than once. So now, under these exchanges, they can ping up against the IRS, they can ping up against Social Security, and see what kind of income you've reported. And they simplified kind of what counted as income, and then they streamlined renewal as well, made renewal easier as well, so that you don't ever have to go in to an office. In fact, I think a lot of the offices now are trying to move even more to sort of even telephonic. So you just call up, press the endless series of buttons, and get your eligibility renewed that way. So to Jonathan's point earlier, so you look at, so where coverage was, we were about 2.3 million before expansion, and then 2.9 million as of November 2005, and I would assume the number is higher now. The number keeps growing. In fact, I'll say that the expansion numbers, as Jonathan mentioned, 650,000 expansion, that is bigger than anybody projected. The take-up has been really good in terms of trying to get people covered, and so it's been a lot more than what people expected. And between 2013 and 2014, Ohio experienced a 38% reduction in the number of uninsured people, the largest sort of reduction in the uninsured probably in the state's history. Actually in the country's history in terms of reduction of uninsured. So I think now the uninsured rate in Ohio is, I want to say about 9.8%, something like that. So very, very much lower than it was in the past. So some other things to think about is, more than half of those covered are working. And that was a big issue in the expansion debate, because there was this, I think this thought that this was going to sort of keep people from working, that this was, that somehow you would get on Medicaid to go to the doctor's office, so you wouldn't have to go to work or whatever. I'm not sure the incentives work that way. But more than half of those who are covered are working. And states that expanded Medicaid have done a much better job of getting health care coverage to those who are working, probably because of this. The rate of uninsured children dropped to 2%. And that Ohio already did a pretty good job in terms of that, down to 2%. But before we were a little over 4, but now down to 2, and that is pretty astonishing. And then the other good thing is that fewer Ohioans report difficulty accessing care, that they're able to get care when they need it, that they don't have to worry about how it gets paid. The other thing we've seen is a reduction in medical debt among Medicaid population. I think one of the things we're a little worried about, though, are folks who are in this exchange, who are in these high deductible plans, maybe sort of incurring more medical debt than they were before. But at least for the Medicaid population, that's not the case. So the other thing that's, I think, kind of interesting, too, this is sort of a complicated chart, but So this looks at, so the other thing people were worried about when we talked about expanding Medicaid, that this was going to be a budget buster, that it was going to really put states in a difficult situation, and that's really not proven itself to be true. And so the piece to look at, the Medicaid enrollment is sort of, you'll see that Medicaid enrollment obviously grew over 3 times faster in expansion states than non-expansion states. I think, Jonathan, you asked me that earlier. But state Medicaid spending, so in all states it grew by 4.5%. In expansion states it grew by 3.4%. And in non-expansion states it grew twice as fast, almost twice as fast, 6.9%. And one of the reasons for that is that when you get people covered, well, one of the things is when you get people covered, you get them into getting care in a better way. To Jonathan's point, they don't all come in through the emergency department. They may get a relationship with a primary care doctor or things like that, become a patient-centered medical home. The other thing that expansion states experienced in terms of spending was that, and this can either be good or bad, probably depending on where you sit, but they had things, states were paying for things that they were able to have Medicaid pay for. For example, people in corrections facilities. The rule in Ohio around Medicaid and prisoners is if a prisoner leaves the jail for more than 24 hours, has to get hospitalized, Medicaid can pay for that. But in the past, most of those prisoners were not eligible for Medicaid. They didn't have kids, but nowadays they are eligible. And so when they need medical care, those costs get charged to Medicaid. Another big area where it saved money was in the mental health system, because the mental health system tended to treat a lot of people who were previously ineligible for Medicaid, those childless adults that we talked about who might have substance abuse or mental health issues. Those costs are now paid for through the Medicaid program. And in the first 3 years of the expansion, the federal government picked up 100% of the cost of the expansion. So it was helpful to states in the short term in terms of cost. Now, states will have to start picking up a portion of that cost, but it's still, I think it's, I can't remember if it's 95 or 90%, but the feds still pick up the overwhelming majority. Now, opponents of the expansion would argue, well, state, federal government, it's all taxpayer money, but if you put your kind of state budget hat on, I think you would agree that for the expansion states have had a much slower increase in their Medicaid costs. Yeah, but the other thing is we still have a lot of uninsured people. So in Ohio, as of 2015, there were about 844,000 uninsured, or 834,000 uninsured individuals in Ohio, and nearly half are Medicaid eligible. And so that's sort of, when I first heard this statistic, a reporter called me from a Columbus paper, and I had seen it online already. I said, if I was still the Medicaid director, that would freak me out. I'd be like, oh my God, 400,000 more people, how are we going to pay for it? I think it's right, and I think, part of it is it's still, even though we've made it simpler, there's still some people who can't get onto the program. And another sort of truism about Medicaid is people tend to sign up when they're sick. They come onto the program and they're sick. Let's say they show up at Metro Health and they don't have insurance. Metro Health is going to do whatever they can to get them onto Medicaid if they qualify, so that they get some payment for that care, and then they're on the program. We used to have a lot, and it's gotten better, but it's still there, a lot of churn on the program, where people churn on and off, so anything we can do to reduce that is good. But if you look at this, so half were Medicaid eligible but not enrolled. 20% were eligible to receive financial tax credits through the marketplace. And Ohio's one of those states that doesn't operate its own marketplace. It lets the federal government operate that. And it seems that in states that have operated their own, they've done a better job of getting people enrolled rather than having the federal government do it. And then 32% were ineligible for financial assistance due to income. They had employer-sponsored insurance. Some folks may be offered employer-sponsored insurance but don't accept it, maybe because cost or whatever. And so they also can be uninsured. And then some, because their citizenship status, they're ineligible for subsidies, either through Medicaid or through the exchange. So here's some of the things that are on the horizon in terms of Medicaid policy, both at the federal and state level. And I'm going to talk about the first one in a little bit. But so folks may remember that in Ohio, Governor Kasich was a big proponent of the expansion of Medicaid. I think I can honestly say it would not have happened if he had not supported it. I tell the story about, I still remember going, this is when I was still at Metro, making a trip down to Columbus to lobby in support of the expansion. And I had like maybe 10 legislative visits kind of back to back that day. And they were all with Republicans. And so I go to the first one. I mean, it was one after the other. No, don't want to do it, not interested. Until I got to the very last person. He was a guy from Southeast Ohio. And he was halfway there. I was like, oh, at least I end the day on a positive note. But for me, it should have showed the real antipathy there was among the majority caucus around expanding Medicaid. There was not a lot of support there. So the way he got it through, and he didn't really need legislative approval to expand Medicaid. That's not the way the program works. But what he needed their approval for was to spend the money. Even though the money was coming from the federal government, you can't do anything in government without an appropriation. And Congress or the legislature controls the purse, controls the appropriation. So he found another way to do it through something called the State Controlling Board. So when this last budget got passed, it wasn't like all those people had kind of changed their mind, and it was still a lot of the same legislators there. And so, nobody will sort of say this out loud, but I think the deal got cut. We will not get in front of the expansion, but you have to pursue these mandatory health savings accounts for Medicaid beneficiaries. And so that's kind of what got written into the budget. And so now the administration is in the process of developing a plan they'll have to submit to the federal government to get approval for requiring almost all adults on Medicaid to participate in health savings accounts.
Can you
Yeah.
describe those?
So I'll talk a little bit, but health savings accounts basically means that you as the Medicaid beneficiary have to pay money, a premium, into a health savings account, and those accounts then can be used to pay for part of the cost of your medical care.
You put your own money in?
Yeah. And they're not like health savings accounts are much more common, in employer-sponsored health insurance. They're not the same as those. They're different. We call them a modified health savings account because there are some pretty significant differences. The other thing that's being eliminated in Medicaid is what's called the spend down program, and this is a program that's been in place for a long time. This is here in Ohio, where if you had high medical costs, you could use those high medical costs to bring your income down for the purposes of qualifying for the program. And so if you knew anybody who was on it, they weren't particularly fond of it. But I always like to point out, well, it gets you coverage. It got you onto the program. But a lot of administrative, you had to keep all your receipts, keep track of everything, so it's kind of difficult. But there's about 30,000 people who are impacted by that change. Some of them will be able to get onto Medicaid, but there's a big group that they've got a little bit more difficult road ahead of them. The other area, I don't know if anybody's involved in the behavioral health world at all, in the mental health world at all, but there's a lot of change underway in that system. And when I talk to those people who work in those agencies here in Cuyahoga County, they are freaking out, for lack of a better word, because they're going to change the rates, what they pay for services. They're going to change the type of providers who can provide the services. And they're adding services and taking services away. And the other thing they're doing, so in the past, behavioral health in Medicaid was always carved out of managed care. So Ohio's a state where if you're on Medicaid, almost all your services are provided by a managed care company. But behavioral health, mental health was left out of that. They're bringing that in. So for those organizations who provide mental health services, today they have one relationship with the state Medicaid program. That's who they bill for their services. In the future, they'll have 5 managed care plans that they have to deal with. And so that adds just complexity. And so, so if you know of anybody who works in one of those organizations, they're freaking out. And then some states, not Ohio, are pushing work requirements. And that has come up on the Republican side during the election. Jeb Bush actually, several months ago, endorsed the notion of a work requirement for Medicaid for adults. Time limits. Arizona is proposing a 5-year time limit for Medicaid for adults. So I don't know what happens if you get sick after that. And then premiums, and premiums even for the poor. I mean, and when I say poor, Medicaid has always allowed premiums above 100% of the federal poverty level. Some states, including Ohio, are looking at premiums below that level, below 100%. And the other thing I like to point out, so the federal government, this current administration, has already approved a variety of these kind of proposals. So they've approved premiums for folks above 100%. I mean, they put limits on them, but they've approved premiums. They've approved cost sharing, meaning that the recipient has to bear some of the cost of services. The health savings accounts, the kind of health savings-like accounts that I talked about. Healthy behavior incentives. This is a big emerging thing in Medicaid, and probably in private health insurance too, sort of paying you something to do something. I tend to think the jury is out on whether any of these programs do anything, whether they're on the commercial side or the public side. But there's a lot of interest in this, a lot of interest nationally in Medicaid circles. Connecting to work referrals. So the federal government, this administration won't approve work requirements, but they'll approve referrals to work services, work training programs or things like that. And then premium assistance. So that's the other thing, sort of approving premium assistance programs as well. So Healthy Ohio. So this, and that's, whenever you have something, nowadays in government, if you put a name on it or something. So we call it Healthy Ohio. And this is the health savings account program. So approximately a little over, and this number is probably higher now, but about 1.1 million people in the state. So 1 out of 10 Ohioans would have to sort of go through this. And just the sheer scope of it is a little daunting. But these two groups over here on the left. And so who pays, so who would be required to enroll in this? So it's charged to all non-disabled adults in the Medicaid program, and there's no exemptions for anything. So no exemptions for medically frail, no exemptions for those with mental illness, no exemptions for those who might be victims of domestic violence, or all these sort of life circumstances or medical conditions that might get in the way. There's no exemptions for those with zero income, for the homeless. So you still have to sort of pay into it. And the premiums are equal to the lesser of 2% of your family income or $99 a year. Now, Arkansas did something similar to this, like this, for people below 100% of poverty, and they eliminated it because it cost them so much more money to collect it than they collected from it. But I don't think that's the point of the people who are proposing it. I don't think they're interested necessarily in how much they collect. What you'll hear them say is they want people to have a skin in the game. They want everybody to contribute towards that, and that's that's a popular message, I think, and I think that's kind of their frame. The other thing, though, is that third-party organizations can pay part of the premium, up to 75% of the cost, which is good, but it also adds kind of another layer of complexity. I don't know how you'll know whether the third party didn't pay for the whole amount. I mean, because the third party organization could give money to the recipient. But you think about the apparatus that you have to put in place to do that. I mean, we talked earlier about streamlining. This doesn't streamline. This makes things more complicated, adds more cost. That doesn't go to healthcare.
What would be an example of third-party organization?
So using my Metro Health example again. So if someone came into Metro and we find out that they had lost their coverage because they hadn't paid, and they show up at our ED and we want to get reimbursed for that, we're going to pay their premium because it would be better to pay that premium and get paid by Medicaid than it would be to give up the $99. So who can lose coverage? So if you go 60 days without paying your premium, you're kicked off the program. And you can't come back on the program until you paid your back fees. You can also be kicked off for not completing the proper paperwork. So if you haven't completed your paperwork in 60 days, you get kicked off the program. The only group that can't be kicked off are pregnant women, although once you deliver, you can be kicked off. So not a good thing. So one of the things we sort of asked ourselves is like, where have we done this before? Because this is kind of a new thing in Medicaid to think about sort of charging premiums to a very poor very low income population and then sort of removing them if they don't pay. So before the Affordable Care Act, Oregon sort of attempted something similar where they had a similar plan with premiums, no exemptions for zero income, and they kick people off for not paying and paperwork and all that kind of stuff. So what happened? So after the premium increase, enrollment dropped by about 77%. So 77% of the people who were on the program left the program. Now that didn't happen right away. It took like a period of a year and a half for that to happen, but we saw that. And so the people who were subject to had higher unmet healthcare needs, reduced use of care, more medical debt, greater household financial strain than individuals staying on the Medicaid program. All the things that we'd sort of that make sense. And the things that we've talked about have kind of gone away, with the Affordable Care Act. So just thinking about in Cuyahoga County, so Cuyahoga County, about 91,000 people have enrolled in Medicaid through the expansion in Cuyahoga County. The number's probably a little bit higher now. So if our reduction was similar to Oregon, we'd have about 70,000 people who'd lose coverage. The effect on the Metro Health System, on federally qualified health centers like Neighborhood Family Practice or NEON or those places, behavioral health agencies would be pretty dramatic. It would really wipe out all the financial benefit that they've achieved. Because that's one of the sort of, I think, maybe told stories, but untold stories about the Medicaid expansion is the dramatic financial impact it's had on those who beforehand took care of all these uninsured people and now who have coverage. There's probably not hospital health system in the state that's not making money, and Medicaid expansion bears a good share of that. The other thing it would do, it would dramatically increase this caseload churn because we talked about somebody could come back on, but someone's got to process all that. Nothing happens just by itself, and so you can see people coming on and off the program. Maybe they go off because they can't pay it. They show up someplace, need care, get it. Someone pays their premium, gets them back on. Then again, they fall back off again. And that's not what we want. We want people to remain covered and remain in the healthcare system. So here's the things I wish were on the Medicaid policy agenda. So the first thing is almost 1 out of 3 Medicaid recipients smoke. They smoke at a rate twice as high as the commercially insured population. That's what I'd like to focus. I'd like to focus on that. And some states have done. Massachusetts Medicaid program has done some really good things around making quit programs more available. All the kind of things that go into that. But Ohio has really kind of decimated its anti-smoking programs. But that's something that Medicaid could focus on, and we could save money. You always try and look for those things. I always look for those things where everything lines up, where all the things line up. So with that one, saves the state money, saves the insurers money, person's healthier, everybody benefits from it. And so that's one of the things I think that I wish was on the agenda. The other is improving Medicaid beneficiary access to long-acting reversible contraception, what we call LARC. And we've been doing some work on this question. And one of the problems now is, in the Medicaid program, is the incentives are not aligned, meaning that when a woman delivers at a hospital, Medicaid pays kind of a bundled rate. So they pay one set amount of money to cover everything. And so if you want to provide this contraception to that woman when she delivers, which is when you would want to do it, the hospital has to pay for that. They don't get any extra money for providing it. And the devices are expensive. They're about $500 or $700. Now the cost is coming down. So one of the things we've suggested is at least unbundle that piece from that rate so that we don't create a disincentive to do this. Rainbow Babies and Children's Hospital, they told me they've spent $1 million on LARC, on long-acting reversible contraception, that they don't get reimbursed for through the Medicaid program. So the state's actually kind of interested in doing this, and so we're going to work with them. But in Colorado, they did a program, actually that was privately funded, where they were able to reduce unplanned pregnancies in that state by 40%. So you just think about so that's one of those things where everything kind of lines up. It saves money, mom's healthier, helps with infant mortality because we increase the spacing between births, it's one of those magic things, I think. The other thing is, Medicaid is the largest payer for AIDS HIV care in the state. And most aren't getting the best care, meaning most aren't getting care that suppresses their viral load, meaning that they aren't healthy, aren't healthier, and they can infect other people. Because when you suppress the viral load, you can't infect somebody else generally. And there are 1,000 new infections every year in Ohio. And we kind of lead the way up here. Our infection rate has actually gone up, particularly, it's grown actually, the numbers are still small, but the rate of increase is much larger in the suburban area of the county than it is in the central city. And so this is another one of those ones where, so we're doing some work with the state, because one of the things the Medicaid program doesn't know now is we don't even know of the people that we cover through the Medicaid program who we know are HIV positive. We don't know how many are in care, how many are getting the drugs they're supposed to get, how many of those their viral load is suppressed. And so those are things. And then the other thing that I think Medicaid could focus on is around the social determinants of health. And what I mean by that is, so like one of the things that we have this experience at Metro, and Rainbow I think has the same experience. So kid comes into ED fairly regularly with asthma and has to get expensive medications, may get hospitalized or whatever. So we can, and Metro, Rainbow, really good at taking care of that kid, getting that kid back together out of the ED. But that kid goes back to that home with all those contaminants that brought on the asthma outbreak. So it might make sense to maybe put some Medicaid dollars there to ameliorate some of those environmental conditions so the kid doesn't keep coming back. Because we can keep treating, we can keep providing the medication, we can stabilize that child, but trying to think about what are those social determinants, those environmental conditions, those social conditions that have an impact on health. There's a lot of research now around housing and the role that housing can play in improving people's health care. Because when you're discharging people to poor housing conditions or things like that, they're likely to come back at a much higher rate than others individuals. So I think folks are starting to talk about that, and I think I think that's probably interesting. So those are the things I would rather have us look for. What are those things where all the incentives line up, where it's better for the individual, it's better for the taxpayer, it's better for the healthcare system, and everybody sort of benefits from it. So that's it, and now I'm happy to take questions. And I should also just say, for those of you, the Center for Community Solutions is also known by our former name, the Federation for Community Planning. So I worked there when it was called that, and now I work here when it's called Community Solutions. But we work on a lot of these sort of health and social welfare issues in Cleveland, have done it for a long time, have offices here in Cleveland and in Columbus. But I'd be happy to answer questions about the Medicaid thing or anything else. Yeah?
Here you go. Here you go.
I was a few minutes late,
John.
so
Oh, yeah.
you may have said what I am asking. My son is uninsured. He has a wife and 2 children, and he's desperately in need of good dental care, and to the point where I think it's a medical issue. And I'm wondering if dental care is covered in Medicaid.
Yes.
And good. And what criteria are there for being part of Medicaid? You mentioned the federal poverty level.
So for an individual to get onto Medicaid, their income can't be any higher than 138% of the federal poverty level, which for an individual is probably around $16,000.
For a family of 4, they are.
Oh, I have to do the math.
Okay, well, that's all right.
Yeah, but yeah, so
I think they're eligible.
yeah, yes, and they can. You just go online. He can sign up online.
Good, that's great to know.
Yeah, yeah.
So when you say that the premium program is because the policymakers want people to have skin in the game, that makes a lot of sense because that provides this incentive for your own behavior.
Right.
But the numbers show in your data that it seems to me the underlying goal is really to kick people out of the program. So when people say we want folks to have skin in the game, how do we respond to that and bring out what their goal really is, which is to make sure that they're not in the program at all to begin with?
Well, I think so. One of the things I remind people is people aren't on Medicaid forever. and for the right reasons, because they advance in terms of their employment or their education, so they get a better job, their income goes up, and they no longer qualify. And before the Affordable Care Act, we really had a problem because it was really kind of what we call the benefit cliff. So you got that little raise, you got 10 cents more an hour, and all of a sudden you've lost everything. Well, now at least you can sort of move into the exchange, get your coverage there with a pretty healthy subsidy, at least up to 200% of the federal poverty level. So I think the one point we make is that, one, people aren't on this program forever. Two, that I'd rather us focus on engagement, rather, that how do we get the patient more engaged in their healthcare? That's the skin I'd rather see. And I think that's a two-way street with both the patient and the provider. How do you get the provider to be more oriented toward engaging the patient, in their healthcare? And I'll get to try all these out because I'm actually have a meeting next month with the guy who wrote this stuff. So he contacted and said he wants to meet with me. So it should be interesting. So if you have any other good ideas, I'll take them and then I'll try them on Representative Price.
Okay, question is here.
Are Medicaid insured people able to get the doctors in Cuyahoga County that they need?
Yeah. So the question is about their access to. Generally, yes. I mean, I think where it's up. I mean, one, I was like, see, like once you work at Metro, you're sort of like Metro forever. But I mean, you have pretty good access to specialty care and things like that. I mean, as a woman who runs the Universal Healthcare Action Network from Columbus told me one time, she said, Metro and Cuyahoga County, it's like Vermont. It's sort of like it's not that way in the rest of the state. I think access is more difficult in other parts of the state, but here in Cleveland, I think access is better. All the providers except Medicaid, all the health, the Cleveland Clinic, University Hospital, Metro, Sisters of Charity, all except Medicaid. We have a really good network of federally qualified health centers. The Neighborhood Family Practice, the Neons, the Care Alliances who provide care. The Free Clinic is a Medicaid provider. So we've got a lot of providers, and I think we have pretty good access.
Primary care as well?
Primary care probably especially. I think primary care access has probably always been stronger. Where it gets tricky is in the specialty care, because that's where, and that's not just for Medicaid folks, that's for everybody, can sometimes have difficulty accessing that. So, other questions?
John,
Oh.
when opponents of ACA complain about the rising costs, are those costs coming primarily from all the administrative issues?
So in terms of the cost, yeah, I mean, in some ways we made it more complicated than, it's like everything with government. Having even worked in it, we sometimes make things more complicated than we need to. But that's usually because the result of compromises that have to get put in place. So I think some of it's that. I mean, there'll be, I think, the higher initial cost because there was also the thought that there'd be pent-up demand. The people who'd gone without coverage for so long were going to access themselves to services. I mean, I've heard of personal, stories like that, where someone got on and got everything done, also because they wasn't sure how long it was going to last. I think people at first were sort of worried that they were going to have it and then lose it. But I think to the where I talked about the things that we should be focused on, the population. We do have to bring down the cost.
Yeah.
We have to bring down at least the rate of growth in cost. But you don't. Like a Healthy Ohio program doesn't do that because it doesn't get rid of the cost. It just gets rid of the payer. And so the person still gets the services, there's just no one to pay for it. And it also pushes people into more expensive settings than the primary care settings that was referenced earlier. So.
And I have to say, because God's making me say it, what do you think the impact of the governor's defunding Planned Parenthood is going to be?
Oh, so I mean that's just, well, it's stupid, but.
With 1,000 cases of AIDS, and
Yeah.
Planned Parenthood being a major provider in this county of AIDS testing.
Yeah, I mean, well, in Cuyahoga County, we're sort of testing. I don't want to say we're testing the wrong people. We are not testing in those communities where HIV is sort of spreading. And so it's not just the providers; it's also sort of who we're testing. And that's a really unfortunate thing because you look at these new infections, they're almost all among young people. I mean, people under the age of 25. So, yeah.
Yeah, to reduce the cost of medications, is Medicaid allowed to invite competitive bids for medications? I know that Medicare is not. What about Medicaid?
So the way Medicaid does that is they have, and I think they do a pretty good job at this. What they do is they can put drugs on a preferred list or a non-preferred list. And the drug companies will do whatever they have to do to get on that preferred list. And so that's how they kind of negotiate. They also can provide, states can negotiate for rebates from the drug companies for those costs. So the way they negotiate is not sort of through a negotiation, but sort of saying, you know, if the cost is this, we're going to put you on the non-preferred list, meaning that, you know, provider has to go through an extra hoop to provide that drugs. And so that's the muscle they have with the drug companies, is to sort of keep them off of that list, that prior authorization list. So,
a lot of the costs for healthcare accrue in the last month of life.
right.
And I think that, you know, when this was all being talked about initially, there were going to be some kind of advisory panels, and then that got labeled as death panels.
Right,
and
right.
was very bad publicity.
Right.
But really there's a lack of understanding of a probability of somebody's recovering to in a meaningful way at the end of life.
Right.
And a lot of it is undergirded by a religious sense that, you know, we're into the last breath and that sort of thing. Is there any way to deal with that part of the cost issue?
So some of that actually just recently, I mean, Medicare now is paying for those things. That they just agreed to pay for that. I think for that, so what I would call sort of counseling or patient education around those end-of-life issues. That tends to be less. I mean, there's some of that in the Medicaid program, but just not. People who, you know, once you turn 65, you go on to Medicare, and so Medicare picks up the bulk of those costs for those people. But there are some costs in Medicaid too. But I don't know that Medicaid. That's a good question. I'll have to find out. I don't know if Medicaid pays for those kind of services now, and maybe now that Medicare is doing it, you know, that might inspire Medicaid to do the same thing. And I just don't know how big that sort of figures in kind of their cost equation. So, oh yeah.
I just wondered, are there people that fall outside the coverage, say the Amish and people like that choose maybe not to?
That's definitely been that's definitely the case here in Ohio. Yeah, I mean the Amish typically do not accept Medicaid, and I'm pretty sure there's a religious exception written into the bill that doesn't require them to. So yeah, you know, because we always had Amish patients at Metro, you know, that came up to Metro. So yeah.
John, I had a question.
Yeah.
What you identified as Medicaid policy proposals that have already been approved. You gave 5 or 6. Are those the same things that have been called waivers that states apply for?
Right.
They are.
Some are through waivers. They're not all through waivers, but some are through waivers. Yeah.
Do you expect that those kinds of changes would be the places we could look for changes to the Affordable Health Care Plan as we go forward? That as states apply for these waivers, that we want to do it this way, that taken in total, that would be an area where the revisions to the plan will be coming from?
Yeah, I mean, so he's referring to the Secretary of HHS has broad authority to waive Medicaid program requirements, and so I think it's Secretary Burwell. So a state can come to her and say, we want to do something like this or like that, and she's able to waive a lot of those requirements. And so you're right, that's how they've kind of done that. I mean, that might be the way you get other states to expand. I mean, you know, we just had this week we had Cindy Mann, who was the former head of CMS, the former Medicaid agency in Cleveland, and you know, and it's hard to argue with approving these things, because if that's the only way you can get you know, states to do this, then you might want to provide some flexibility, because it might not be the perfect way to do it. I mean, the way Ohio did it is the best way to do it. It's pretty straightforward, pretty simple, you know, and cheaper, I think, too. It just adds costs and complexity. I mean, Medicaid is already the most complicated subject in the world, so I wouldn't want to make it any more complicated. So, yeah.
I'm wondering if lead abatement is something Medicaid can cover.
They can't cover it today, but you know, there are ways to do it. So one way would be so one of the reasons we do Medicaid waivers sometimes is to actually add benefits or add services. But in order to do it, you'd have to prove to the federal government, if we do this, pay for these things that Medicaid doesn't pay for with Medicaid, we will save this much money. And you can't spend any more than you would spend if you hadn't covered those things. So that's one way to look at it. And some states have kind of, not so much on lead, but on other issues, are starting to go down that path, that sort of population health path. The other way to, one of the things, Ohio, we've got all these Medicaid plans, these managed care plans in the state. They could pay for those things today. If we could figure out, how to get them to use some of the flexibility that they have, at least to try it. I mean, I don't know that I would sort of advocate for doing something wide scale. I'd want to try it and see if it works, and because you would want to show, I think that the point of doing that, one, to get the person healthier, but also to show that you can reduce costs, because all those other costs, that come down. Oh.
In New York State, where we have a house, we know we pay a certain amount of money towards Medicare. Medicaid.
Medicaid, yeah.
And what's the situation in Ohio?
So New York State's kind of unique. I don't know if it's unique. I mean, they always say when you've seen one state Medicaid program, you've seen one state Medicaid program. They're very different. But New York State, the counties there, counties in New York pay a part of the Medicaid bill. So they put up part of those matching funds that the state's required to put up. And so counties there have the levy taxes on their residents to help cover that. That's not the case here in Ohio. Counties are not responsible for paying a share, by and large, of the Medicaid program. So
yeah, I've always wondered that because it's broken down. My county taxes in New York State are $4,000, and of that, $2,000 is Medicaid.
Yeah, New York is one of the few places in the country that has a county level tax. In fact, one of the things that Ohio did, we used to require, the one thing that we used to do in Ohio was we used to require local counties to put up the Medicaid match for mental health services. And so the local mental health board, and we would pay for that through the Health and Human Services levy. We did away with that. Now the state is responsible for paying all those matching funds for mental health services. So it's different in New York, you're right.
It certainly is.
Yeah. Oh.
I wondered if you've been on Medicare most of your life, and you then are eligible for Medicaid, what happens with all the specialists that you go to? How do you know whether they're going to cover you?
So all the you could look at all 5 Medicaid managed care companies have provider lists. So you could look and see if you could choose a plan whose providers are included. But in general, at least here in this area, almost all, I mean, I know Metro had contracts with every single Medicaid managed care plan, so everyone's covered through their network. And I tend to think that's probably the case with the others too. The largest Medicaid provider, Medicaid managed care plan in this area and statewide is called CareSource. It's a plan that's located out of Dayton. They're the only sort of local, statewide plan. All the rest are national plans. But I would look, you could go online and look and see to check, make sure those health systems, I assume you're seeing providers, almost all the providers here in Cleveland are affiliated with one of the hospitals or health systems, but you could look and see whether they're included on their panels or not. But they have pretty broad coverage. Sure.
John, I got
this is Carter Strang, one of my board members.
He's doing a great job. He didn't ask me to say that. We're happy to have John.
Excuse me a minute here so we get on
Sure.
tape. Thank you.
John, one of the things that one would expect with the expansion of coverage that you've talked about, particularly in Ohio, is one would expect infant mortality rates to decline.
Mm-hmm.
But we have very high infant mortality rates as a country,
Right.
particularly Ohio,
Right.
Among all the states.
Right.
So could you speak to that disconnect?
So the one thing is that's a good point, because the point I always make about infant mortality is all those babies are Medicaid babies. By and large, Medicaid pays for most of the births, in the state. It's a little early yet. We don't have a lot of health impact data yet. But I would expect that the coverage will have a positive impact on that over the long term, because one of the things, if you talk to physicians, they'll say that a lot of the problems that mom or that baby might have relate to health conditions that don't have anything to do with pregnancy. It's their diabetes, it's their hypertension, and these were people by and large, especially if they didn't have kids, who weren't eligible for Medicaid before, so might not have been in a situation where they had ongoing primary health care. So we hope that getting them covered, and if we can keep them in care, before they're pregnant, and also that way it's more likely that they have a relationship with a physician, because you still hear about people kind of showing up, in the last trimester of their pregnancy and stuff that no one's seen before, or they haven't been known to a health system as pregnant. So maybe those two things, getting them coverage, care for some of those chronic diseases like hypertension, diabetes, obesity, and also establishing some sort of relationship with a physician, somebody who's kind of paying attention to them.
Do you expect that number to improve?
Yeah, I do. I also think we're getting more focused on it. I mean, I was over at City Hall last week, and I said, the big difference is there's like political leadership focused on it now. I mean, that's half of the battle, is just getting the political will to do something. So everybody is, I think, more focused on it now and really wants to try and bring it down. So that's good. Great. Thanks, everybody.
Thank you.
That was outstanding. Thank you. A couple of brief announcements. Next week's forum is entitled European Union and Immigration. High stakes, what's the future? Is the European Union as strong as it once was, given the challenges of immigration? What effect will European immigration problems have on U.S. immigration policy, with thousands of Middle Eastern citizens coming to the United States? The moderator will be Margaret Wong, Senior Managing Partner, Margaret Wong and Associates, with panelists Stephen Hook, Professor of Political Science at Kent State, and David Goldberg, Professor of Labor and Immigration History, Cleveland State University. As well, that's next week, Sunday, March 6th. Today, the sermon will be conducted by Reverend Beth Marshall, entitled Sacred Work, and that's today. Once again, thank you.